Hello everyone and welcome. My name is Peter Monteleone. I'm an interventional cardiologist at the University of Texas at Austin Dell School of Medicine. And today I'm going to be talking a little bit about stent selection and algorithms for stent selection for aortoiliac disease. These are my disclosures. Before I begin, I'll mention and reference the SCI guidelines on device selection and aortoiliac arterial intervention. I'd refer you to these. It's an excellent read listing quite a bit of information present in this field. For considerations for today, we'll be talking a little bit about safety for devices, data for devices, and differential considerations with regards to anatomy, tortuosity, osteal interventions, considerations about the internal iliac artery origin. For options, we're going to be talking about balloon expandable versus self-expanding stents, covered versus uncovered stents, and we'll raise the topics of drug-eluting stents and also any role for bifurcating stent grafts. We'll begin with balloon versus self-expanding stents. So balloon expandable stents have certain benefits, including precision of deployment, allowing for quote-unquote sticking the landing. Also the radial force integrity, particularly at the stent edge with balloon expandable stents. Self-expanding stents have their own strengths, including how conformable these stents are for severe tortuosity within iliac vessels. We'll try to use cases to identify some of these strains. So case 1 was a gentleman with severe left lower extremity claudication, and he had this discrete osteal left common iliac artery lesion. Thinking about therapies for this focal lesion, there was absence of contralateral disease. The consideration was, is it possible or appropriate to quote-unquote stick the landing at that common iliac artery origin? And so we used a balloon expandable stent for allow for precision deployment. We had an omniflush catheter up from the other side, allowed us to visualize exactly where the origin was, and allowing us to optimize position of our stent. We then deployed, indeed there's a millimeter or a couple millimeters of overhang into the contralateral side, but beautiful angiographic result on the common iliac artery without significant compromise to the other side really allowed us to place our device exactly where we needed it. And on the full aortoiliac angiography, a really excellent angiographic result. So balloon expandable stent in this situation allowing for precision of deployment and allowing us for effective radial force at the distal edge. Case 2 on our aortoiliac angiogram, we see evidence of a severe lesion right kind of at the bifurcation of the internal and external iliac arteries. When we take an off-axis picture, this lets us see even better how critical this lesion was within the proximal external iliac, right at a level of a severe bend. We used an omniflush to get up and over with a glide wire. That allowed us to bring a sheath up and over into the common iliac artery, and then IVUS is utilized for pullback, for sizing, and for visualization of the lesion. We help size effectively the lesion. We see how critical that disease is with heterogeneous plaque, and we choose a device. An important key for iliac interventions, because the risks of perforation are so dramatic in this open space in the retroperitoneum, is we used undersized balloon inflation, then full-size balloon inflation. Then that allowed us to position a self-expanding stent to allow it to conform to the severe tortuosity of the vessel. There's our lesion before intervention, and then to the right is our lesion after intervention. Really an excellent angiographic result. Now we see, despite using an open cell self-expanding stent, we do see compromise of the ostia of that severely diseased internal iliac. The contralateral internal iliac is open though, and also we do see filling via collaterals into the left side of internal iliac as well. Self-expanding stent in this situation allowed for excellent conformability for the severe tortuosity extending into the external iliac. It was an uncovered stent to allow to minimize occlusion of that internal iliac at the origin. Next, we'll focus on covered versus uncovered stents, thinking about some data, thinking about some safety uses, and also anatomy. So the COBEST trial, performed mainly outside of the United States, used the V12 covered stent, and indeed it demonstrated a significant benefit in terms of total binary restenosis utilizing covered stents versus bare metal stents. As we applied covered stents into tasks C and D complex cases, we see an even more dramatic benefit. With long-term follow-up out to 108 months on the left side, we see this improvement again with covered stents. Even more improvement again with the task C and task D complex lesions, speaking to the benefit of covered stents in these patients. It is worth noting that the patency of the bare metal stents was quite low, 25 to 30% out, so worse than we would have expected for bare metal stents within the iliac region. So grain of salt when considering this data. The newer kind of VBX covered stents also shown pretty dramatic outcomes data, 98% patency extending out to 38 months for clinically driven target lesion revascularization with this novel device. Really excellent. The SKY guidelines touch on this use of covered balloon expandable stents, as we see on the left. Covered balloon expandable stents gaining a Class 1 recommendation with a strong level of evidence at the bifurcation in common iliac lesions and also in higher risk calcified or diffuse lesions. For self-expanding stents that are covered, less data, 2A and 2B recommendations for use of covered self-expanding stents, secondary to less data. In the next case here, what we see is a common iliac artery occlusion within about a centimeter of the actual origin of the common iliac artery. In this situation, we were able to very smoothly cross retrograde and utilize IVUS to demonstrate an intraluminal path, an absence of much calcium, and very clearly re-entering within the common iliac artery prior to origin within the aorta itself. In this situation, decreased calcium, a smooth intraluminal path, very comfortable with this lesion using an uncovered stent. And so we pre-dilated, undersized, and then at-sized with a covered stent, really with an excellent angiographic result. So this was a CTO, but soft plaque, not heavily calcified. We knew we had definite intraluminal crossing. And so there was some benefit as well using an uncovered stent and trying to avoid a covered stent at the ostia to avoid accidental covering of the contralateral common iliac artery, since we were avoiding intervention on that side secondary to absence of disease. It's a really nice result with an upward balloon expandable stent in that situation. In the next case, again, we see severe, really bilateral disease. Our focus here is on the left iliac artery, which is completely occluded at the left common iliac artery, again, within about a centimeter or so of its origin. In this situation, we attempted to cross retrograde, and this was not successful. This wire is far off from the origin, likely in a collateral vessel, unclear where the wire path was. Managed with a glide catheter and a trailblazer to get a little bit closer, but still not able to access retrograde, certainly not able to stay true lumen. We were, however, able to get up and over using a 6 French coronary guide for initial navigation and passage, using a stiff angle glide wire to pass into the beak and then down true into the left common femoral artery and superficial femoral artery. We then used shockwave. So shockwave allowed for controlled expansion of a heavily calcified common iliac artery, also extending into the external iliac artery, and an angiogram on the right shows the external iliac artery now filling. Placed a self-expanding stent to conform to the tortuous external iliac artery, and then by going up and over, placed a covered VBX stent to full size after that pre-treatment shockwave. This resulted in a very nice angiographic result, complete resolution of claudication symptoms. In this situation, we have data suggesting benefit, particularly of task C and task D lesions. We also gained an element of safety by using a covered stent in the setting of a complex crossing of a chronic total occlusion. With regards to drug-eluting stents, very limited data, and so no clinical recommendation within the SKY guidelines for benefits of drug-eluting stents within aortoiliacs. And I leave with this, not all iliacs are simply treated with only a couple decision points. This complex artery demonstrated evidence of fairly pronounced iliac artery ectasia and aneurysmal change, bilateral disease, a fairly small distal aorta. You can consider covered bifurcating grafts previously used solely for AAA in this setting. You can consider aortobifem in this setting. This was a patient who had really only mild claudication symptoms. We opted for medical therapy and monitoring of that iliac ectasia over time. So certainly many new considerations coming for device utilization every day. So thank you all so much for your time. I'd be very open to receiving any questions as they may come. I appreciate your attention and wonderful speaking with you today.